What I'm going to try to do is go over, in the first talk, aspects of anaphylaxis and then acute therapy of asthma. And I'm really trying to give you some clinically useful things to think about and to put into practice, and then hope that you can pass the questions on your board test that might be applicable to those areas. We'll start with the first topic is anaphylaxis. And this has been difficult to really define, but I think it's thought of as a syndrome that is a multi-system syndrome resulting from the rapid release of mediators from mast cells and tissue basophils. And these are chemicals that are in these, kind of prepackaged and ready to roll. And when the cell is activated, they spill out just within seconds to minutes, and that's why it can be of such acute onset. It varies from mild to fatal, and you hear the term anaphylactoid. It is the same clinical syndrome, but these appear to be non-IgE mediated. So anaphylaxis is IgE mediated, and anaphylactoid is by some other mechanism. So kind of the take-home there is that there are different mechanisms for this. It isn't all just an immediate hypersensitivity reaction. The initial studies of this, although it goes back to wasp stings back in Egypt, killing the pharaoh, but in 1902, two investigators in France, Poitier and Richet, studied anaphylaxis in a dog model. And the Greek for protection is phylaxis. And they found that when they injected toxin from the Portuguese man-o-war into dogs and then re-injected them a few weeks later, that rather than having an antitoxin effect, they all died. So they came up with the concept of anaphylaxis, or the opposite of protection. Now the incidence is kind of hard to come up with, but in Manitoba and the Canadian provinces track prescriptions pretty closely. And they found that about 1% of the population in Manitoba had prescribed epinephrine. And the greatest incidence of this was in younger people at about 1.4% of the population. So it's at least a 1 to 2% prevalence condition. There was a study in the UK of admissions to the hospital for anaphylaxis from 1990 to 2001, and it was found to be increasing, and this is attributed to either or the increasing use of drugs, polypharmacy, and also perhaps the increase in allergic diseases and atopy in populations. So it's an increasing problem. Now the mechanisms are first IgE mediated, and this is IgE sensitized mast cells, and when they're exposed to an allergen, let's say this toxin, there is bridging of the mast cell IgE to antigen, and once they come into a certain configuration, it gives a signal to the cell to release these mediators, and very quickly comes out of the cell things like histamine, tryptase, leukotrienes. Some of them are preformed, and some of them are generated after the signaling occurs. Common causes of IgE-mediated anaphylaxis would be things like foods, peanut, tree nuts, shrimp, insect venom stings, latex allergy, a lot of the antibiotics like penicillin, and then immunotherapy with inhalant allergens or venom immunotherapy would be common causes. The effects of mast cell mediators are in large part histamine, but probably the other mediators as well, but they have direct effects in the skin of causing pruritus, mucus secretion, increase in vascular permeability, and bronchoconstriction, and all these are important mechanisms in the evolution of the anaphylaxis syndrome. Now there are other mechanisms that aren't just IgE. One is complement activation, and this examples would be radiocontrast dye. People have anaphylaxis with that. It's probably not, it's not IgE, it's somehow complement activation and then a signal to the mast cell, IVIG and blood products. One thing about radiocontrast is this idea that it has something to do with shellfish or iodine is really kind of a medical urban legend. It just doesn't, they're not related in any way. A couple other mechanisms, things like morphine, seem to directly perturb the cell membrane of the mast cell. So it causes some kind of signaling to release those mediators. There's some muscle relaxants like succinylcholine and some antibiotics like vancomycin. So this red man syndrome of vancomycin is histamine release just by some direct contact. And then there's arachidonic acid metabolism, aspirin, and the NSAIDs can cause anaphylaxis. Some of those may be IgE, but others may be some other kind of biologic mechanism. And then there are the idiopathic syndromes, and a couple are they're interesting. One is exercise-induced anaphylaxis, and these are people, usually very atopic, younger people who go out and run, and as they are running, they start to have generalized itching and maybe throat constriction, and can actually have shock. And it's not known how that gets activated. There is a subgroup called food-dependent anaphylaxis, exercise anaphylaxis, and these people seem to have to eat a certain food within a couple hours of exercise, and that triggers it. And classically, people can eat the food without a problem. They may be able to exercise without a problem, but if you put these two together, they'll have anaphylaxis. Yes?
Is that the same as eosinophilic fasciitis? Exercise?
Is that the same syndrome as eosinophilic fasciitis? I think that it'd be a different syndrome. It is probably some kind of hyper-releasability of mast cells, but it's not known what the biology of it is. And then there's the idiopathic anaphylaxis syndrome, and this is actually very common. And these are people who are going about their business and all of a sudden had an anaphylaxis. They're worked up by every test imaginable, and no cause or triggering factor can be identified. In fact, at Northwestern University, they follow about 300 of these people, and some of them even need steroids as well as a lot of other medicines to control this because they can be very violent. So not everything that we see will have a clear triggering factor, and I'm able to come up with in an emergency room population. And the first would be in Olmsted County, which is Mayo Clinic. They found that probably the majority were foods, and this is similar in a Brisbane study. Drugs are important. Insect stings were about 1/6 of the patients, but almost either from a fifth to a third were in this idiopathic category, even with very detailed evaluation. Now, the clinical manifestations reflect the effects of these mediators coursing through the system, and I think it's important to think about those because they help us with diagnosis and to understand how the treatment works. Urticaria, angioedema, itching, and a flushing appearance to the skin are extremely common. People would have welts or facial swelling, lip swelling. In the upper respiratory tract, it can be anywhere from tongue, pharynx, larynx, acute nasal congestion, itchy eyes, and in the lower respiratory tract, an asthma-like syndrome. In the cardiovascular system, tachycardia usually, the hypotensive, and shock with intervascular volume loss. They can have bradycardia by a kind of a reflex mechanism in the left ventricle, and that makes it hard to distinguish this occasionally from kind of vasovagal reactions. If there's decreased perfusion into the coronary arteries or mediator effects, they can have myocardial ischemia and rhythm disturbances. There's a lot of pooling of volume in the GI tract and swelling of the GI wall, so they'll get nausea, vomiting, cramps, and diarrhea. And then there's just a general sense of anxiety, faintness, lightheadedness from lower blood pressure, and the famous impending doom feeling that has been described by a lot of these folks. Now, this is a series of about 340 patients who were evaluated as to the major manifestations of their anaphylaxis. And I think it's really important in trying to make quick diagnosis to recognize that 90% or so will have hives or swelling. And then flushing occurs in about half of them. So if you put the cutaneous symptoms together, most of these people will have some kind of skin manifestation. So if we go to in the emergency room or in the office and see these people, most of the time you'll see that as a manifestation of evolving anaphylaxis. Kind of interestingly, out of these people, almost half had shortness of breath or wheezing. A third were hypotensive, and GI symptoms were common. Now, in a few people, the only manifestation is an acute shock response. And it may be that the mediators get to the blood vessels, they vasodilate so quickly that there isn't enough perfusion into the skin to get the skin manifestations. So a few of these just will have a shock syndrome. And this is a series from Scandinavia with 27 severe cases in shock, and 30% did not have any skin findings. Most of them had some neurologic manifestation, probably poor perfusion, and there were deaths and hospitalizations in this group. Now, the temporal sequence is important to understand because it has implications in thinking about disposition of the patient and therapy. Most folks are going to have what's called uniphasic anaphylaxis. They get their penicillin shot or their allergy shot, and they have acute anaphylaxis, and then it resolves. But there are some people who have what's called biphasic. They'll have the immediate reaction, it'll get better, and then it'll come back, usually within about 8 hours. There's another pattern called protracted, and they just have waves of symptoms out to 30 hours or so. And then there can be what's called delayed, and this is not as common, but they may not have symptoms for a period of hours after the antigen. Sir?
Are there any general percentages?
Yeah. In terms of in adults, this is reported to be about 5 to 20% of anaphylaxis episodes, and it's less common in children, about 2 to 3%. The recurrence can be as late as 28 hours later. And it appears to happen more often in the real severe initial reaction, and also if it has sort of evolved over a long period of time. They've been having symptoms for a couple hours before they finally see you. It is said that it's either the same, worse, or milder than the first one, but most people think that it's similar to the initial wave, and usually the same systems are involved.
When a person has biphasic reaction, if they're exposed another time, will they all be biphasic again?
Yeah. The question is, if they had one biphasic reaction, is there a higher risk that the second one would be? And yes, that seems to be the case. In the UK, they have come up with some, this Resuscitation Council guidelines came up with some recommendations about how to think about the patient who's come in with an initial anaphylactic episode and how long might you keep them in the hospital. And if it's a severe reaction, particularly if it evolved kind of slowly, think about keeping them in the hospital for 24 hours. If they had a previous biphasic reaction, the risk is higher. If they have asthma, that's a very significant risk factor for more severe anaphylaxis, so they should be in the hospital and monitored. And if they've eaten a food to which they're sensitive, let's say peanut, or it's a penicillin product, you could imagine that there could be kind of waves of absorption and maybe recurrence. So I think you have to make this kind of judgment as to what the risk is that this would come back when you see the patient in the emergency room or in your office. And if it's pretty severe, I think you can very much justify putting them in the hospital for observation so that you're ready to treat if it does recur. But there aren't clear guidelines predicting who's going to have a second wave of symptoms. Now, the diagnosis is usually clinical. There's a scenario with ingestion or a sting, and then pretty clear clinical symptoms, hives, itching, swelling, wheezing. But occasionally, one might need some kind of laboratory study to investigate this. And there is tryptase in these mast cells that is released, and it peaks at about 90 minutes after anaphylaxis starts. And people have done tryptase measurements, and it's been used forensically. Let's say the farmer goes down in the field and the cause isn't clear. Tryptase may be elevated if it were anaphylactic. One could also maybe investigate factitious anaphylaxis. Somebody said, I had this horrible reaction an hour ago and now I feel better. You might do a tryptase level. Plasma and urinary histamine have also been looked at, but these are tough assays, and usually we don't do this kind of study. But I just wanted you to be aware that this tryptase is something that's occasionally used to be more clear about whether it is anaphylaxis. The prototypical anaphylactic, if you just had to come up with the average patient, female more than male, usually very allergic individual. It's usually related to food ingestion, peanut or tree nut, and hives and swelling and itching are usually the first symptom that you'll see. This is a series of fatal food-induced anaphylaxis from Dr. Bach, and they looked at 32 cases of subjects who died with anaphylaxis. And in this series, they were virtually all adolescents or young adults. Peanuts and tree nuts were the cause in over 90% of the cases. And I think very importantly, 20 out of 21 had asthma. So again, asthma is a very significant risk factor. And most didn't have epinephrine available, although virtually all of them had it prescribed at one time for food sensitivity. So you can see some risk factors here. Some of it may be adolescent behavior, and then a very dangerous sensitivity. Now, the differential is occasionally difficult. Vasovagal syncope would be one thing you'd have to always be considering. Let's say you give an antibiotic injection in the office and somebody goes down in the room and you rush in and you're trying to figure out what's happening. Is this anaphylaxis or vasovagal? And classically, the subject would have kind of a pale appearance and respond to recumbency and usually bradycardic. They wouldn't be flushed. There wouldn't be maybe a local reaction where they got their injection evolving. But this is sometimes difficult to distinguish right away. MI, PE, hyperventilation, if you again look for skin findings, blood pressure, I think you'll be able to distinguish those. Now, some risk factors for more severe or even fatal anaphylaxis, a couple are pretty important, and one would be beta adrenergic blocking agents, beta blockers, because they're going to block the effects of kind of endogenous catecholamine response to anaphylaxis. And if you give epinephrine, the epinephrine may not be able to get at the beta receptor. So that's a risk factor. ACE inhibitor drugs, one response to shock and lowering in blood pressure is angiotensin generation. And if you block that angiotensin II effect on blood vessels, they may not be able to vasoconstrict as well with that hypotension tendency. If they have cardiovascular disease or pre-existing lung disease, they're just not going to be as resilient as these pathophysiologic events evolve. And then tricyclic drugs and MAO inhibitors kind of actually, they don't make the anaphylaxis worse, but they potentiate the epinephrine systemic effects. and there can be epinephrine toxicity. Now, the physiology of severe anaphylaxis, it's important to kind of think about because it kind of drives how we would treat. There's an initial arteriolar vasodilatation, and the mediators, particularly histamine, will cause initial vasodilatation. After a little while, there's kind of reflex mechanisms that vasoconstrict, but initially there's decreased systemic vascular resistance and decrease in effective intravascular volume. And that's driven also by this capillary, post-capillary venule leak phenomenon. The mediators make the blood vessels leaky, and you can lose up to 50% of intravascular volume in 10 minutes with severe anaphylaxis. So they are volume depleted very quickly, and then you get pooling, particularly in the GI tract of volume. And so cardiac output, it starts to decline as you get decreased venous return. So this is the shock response. In terms of the pulmonary physiology, this is an acute asthma event. There can be upper airway obstruction from angioedema and then kind of an asthma physiology. And actually, this is probably the pathway of death in most asthmatics is the airway path. Now, the management, we start with just the basics of CPR and checking airway, breathing, and circulation, assess level of consciousness, a focused history and physical exam, and then get vital signs, wait for drug dosing, particularly in kids, and get a flow sheet going. And at the end of the handout is kind of a flow sheet you could think about using in the office that has timing and when epinephrine is given, et cetera. And then I think it's important to try to think about whether you are going to continue to manage this patient where you are, or do you need to start thinking about transfer to a more tertiary care center if that's available. Now, it's not available for everybody, but try to make those decisions about whether the office environment is the place you want to be managing this patient. If we think about the therapy, this slide probably capsules the major things to think about, and probably any test questions on your board would come from this in large part, because epinephrine is just the cornerstone of therapy. After that, you try to get the patient into kind of a supine position with the legs elevated to improve venous return. There's something in severe anaphylaxis called the empty heart syndrome, and venous return is so poor that when some of these subjects stand up, there's just no blood to pump, and they have asystole. So try to encourage the patient to be down with the legs up. Occasionally, if they have asthma or a pulmonary process going on, they're not going to want to do that. They may want to be up to be in a more mechanically advantageous position, but legs elevated is something to try to encourage. Think about oxygen. If there's been an injection, perhaps think about a tourniquet above the site. It's not proven that that helps, but it's sort of intuitive to think about doing that. Think about IV access and fluid administration. And then as you go along, things like antihistamines and steroids may come up, but they're really secondary therapies. They don't really get at the pathophysiology of anaphylaxis in any kind of immediate way. Steroids don't start to work for at least an hour, maybe even longer. So this is in a very acute process, and steroids don't really affect that acute evolution. They may attenuate late phase or these biphasic or protracted anaphylaxis, but they don't do anything for the acute event. Now, epinephrine is the first line drug of choice in anaphylaxis, and because of its mechanisms, it has an alpha agonist mechanism that increases blood pressure by vasoconstricting peripheral vessels. And then the beta agonist mechanism is bronchodilating, it's inotropic, chronotropic, and it actually kind of turn off mediator release from mast cells. So there are a lot of different ways that epinephrine is effective in the syndrome. There are studies that we'll talk about in just a second that have demonstrated that giving epinephrine IM is preferred. And the doses generally in adults are 0.3 to 0.5 milligram of 1 to 1,000 epinephrine, and then in kids 0.01 milligram per kilo. And this can be repeated every 5 to 15 minutes until you get a favorable response. IV epinephrine might be thought of in patients who are refractory to repeated IM, epi, and fluids, but it would be down the line because of safety issues. Side effects of epinephrine would be hypertension and rhythm disturbances, but don't withhold epinephrine because of any cardiac history. This is too threatening a syndrome. On balance, you're going to do more good than harm by administering it. Now this is yes?
Sorry, what was the dosage for children?
The dose for children?
Epinephrine, yeah,
Yes.
the dose of epinephrine for children.
The dose for epinephrine in children is 0.01 milligram per kilo. And again, every 5 to 15 minutes. Now this is a study that was done in Canada by Dr. Estelle Simons, who studied anaphylaxis about as much as anybody. And she kind of asked the question, what is better, IM or sub-Q administration? So she had children who'd had anaphylaxis at one time and were willing to be injected with epinephrine in a study. And she found that by either route, the mean plasma epinephrine concentrations were about the same. But in the sub-Q group, it took 34 minutes to get a peak epinephrine effect, whereas in the IM administered group, they reached a peak at 8 minutes. So in an acute condition like this, you're getting much quicker epinephrine levels with intramuscular administration. And then the number of subjects reaching peak epi in less than 5 minutes were much greater in the IM administered group.
So were these sick people having an attack?
No, that's a good question. These were not people with anaphylaxis. They had had it, and they had had epinephrine for anaphylaxis at some time in the past, but they were studied when they were well. It's just so difficult to do studies in people who are having the acute event. And then she also looked at giving intramuscular epinephrine in the thigh, in the lateral, in the vastus lateralis muscle in the thigh, and she found that the EpiPen device, IM, and injected epinephrine just out of a syringe had about the same peak levels, and they were considerably higher than if they were injected into the deltoid. So from this, she has recommended that epinephrine be given into the lateral thigh, like you might with EpiPen or with the new TwinJect. So that's maybe different than 10 years ago, where sub-Q was always the thing that was talked about. I think in a test question, I could imagine somebody saying, which is better, IM or sub-Q, and it is not. The answer now is IM. There are two products now available in the US, EpiPen and TwinJect. EpiPen's been around for a long time. The dose in the EpiPen for adults is 0.3 milligram, and the EpiPen Junior 0.15. And generally, you use the Junior up to about 60 pounds, and then you go to the EpiPen. They now package this as a 2-pack, and so you get 2 devices, and the reason for that was some studies that showed that when people came to emergency rooms, 50% of them needed 2 injections of epinephrine. So the idea was these people are out in the field and they have, let's say, yellow jacket allergy, and they get stung. There's a delay till they get to care, so give 1 EpiPen, and then if you need more, you have a second one available. What people unfortunately probably do is they put one in their gym bag and the other one in the truck, and so they don't always have 2 there. But that's, You can get single EpiPens still, but it's marketed pretty much as this 2-pack, and that's the reason. And then there's a trainer in there so that they can practice. And I think it's good if you use these and have these in your office, just to kind of briefly have you and your personnel go over the proper use of it, because you hate to have to pass this test when everybody's running around and somebody's very sick, how to work these. But it's given in the lateral thigh, and the trainer looks different than the real thing, but they push it into the lateral thigh muscle and then hold it for 10 seconds so that all the drug is ejected out of the cartridge. There's also a new product called Twinject, and they also have a 0.3 milligram and a 0.15 milligram. They have 2 doses in this one device, and you take this kind of blue-green part off, and the needle is inside a kind of a plastic hub, and then you take the red part off, and that allows the spring mechanism to work. You give it, and then you take off the part you kind of had used, and then there's a smaller needle in there that has another dose. So I think I gave a website for that, and they have a video, and if you use this product, I think it's important just to look at the video because they go through how to use it. And then in the Twinject, there's an instruction sheet as well. And I tell patients to reread that every couple months and think about it and even look at the video again to be sure they're confident about using it. Now, IV epinephrine is something that might be considered if patients have been given IM epinephrine, they've been given fluids, and they're still hypotensive. There may be a role for this. The doses are inferred from cardiac care guidelines. There's no way to study this really very well, but people have come up with doses that might be used for intravenous epinephrine. And I've just given you some of these doses that have been used in adults and then in children. And there's a reference there that's also in your references at the end of the handout. And I think one would just have to have these in a clinic situation and go through how one would get the epinephrine put together and infused if you're dealing with this kind of problem. Some people have also used things like dopamine, and there are studies of vasopressin in anaphylaxis as well to see if these have advantages. A couple other routes of epinephrine administration. It's been given under the tongue by injection if you can't get an IV access or they're so poorly perfused peripherally. Given down an endotracheal tube. It's been given like Primatene Mist, 15 puffs, let's say. And then there's a new product that's being looked at, which is an epinephrine tablet that's given sublingually. And they developed this because it turns out a lot of people are very averse to administering this IM injection. You have this life-threatening condition. You'd think people would do what they would be life-saving, but a lot of people are afraid of doing it. And this tablet is about 40 milligrams of epinephrine, and it appears to generate the same blood levels as 0.3 milligrams of intramuscular epinephrine. So that's in the works, and there are Canadian studies of that, and I'd just kind of watch for that sometime in the future. Now, causes of epi failure, it doesn't always work. And some reasons are that the anaphylaxis has evolved too far, and epi hasn't been given promptly enough, inadequate doses are given, or it's given improperly, it's given sub-Q, or patients are taking a beta blocker. That might be a case where it just doesn't seem to work. Now, the next thing to consider in treatment would be oxygen. This respiratory insufficiency, particularly if they have asthma, can progress very quickly. So supplemental oxygen would be something to think about if in any but very mild anaphylaxis. Try to keep saturations in the mid to upper 90s. When they hit, if they don't have a lot of other lung disease, if they hit about 90%, it's not a good sign because they can really trough out after that very quickly. Now, volume resuscitation, we said that there is a significant drop in intravascular volume. There were some cath lab studies that showed that you could measure a 50% drop in intravascular volume in about 10 minutes in severe anaphylaxis. So these people get very volume depleted very quickly, and that's the rationale for very aggressive volume resuscitation. If you've given epinephrine one or two doses and their blood pressure stays below 90, in adults that would be a reason to start giving saline. And the doses usually talked about are 1 to 2 liters. You can give, and in children it'd be 30 milliliters per kilo given within the first hour. And then after that you can bolus 5 to 10 milliliters per kilo just over a few minutes to try and get the pressure up. It appears that saline in anaphylaxis is maybe the best choice. I think there's a lot of debate in shock whether, what the best replacement is. Some people have used colloid, but it appears that saline is preferred, and it's probably better than lactated ringers for some metabolic reasons. So just think saline and think aggressive volume resuscitation. This is just some values on what would be hypotension in children, and so that's going to be different than the older child and adult. How about antihistamines? In a guinea pig model of anaphylactic shock, they found that histamine reproduces anaphylaxis pretty closely. If you pre-treat with an H1 antihistamine, they'll still get hypotension. If you pre-treat with an H2 blocker, they'll still get hypotension, but if you use both, it blocks the hypotension. So that's been the rationale for using combination H1, H2 blockers in particularly hypotension and anaphylaxis. The H1, just giving Benadryl or diphenhydramine may help itching, but it doesn't really get at those cardiovascular pulmonary processes that are the most important. So we can give antihistamines, but we're just really relieving symptoms of itching and hiving. Diphenhydramine can be given as just one example, 25 to 50 milligrams for adults and then 1 milligram per kilo for children. H2 blockers would be added, again, if there's hypotension not responding to fluids, and commonly one would use diphenhydramine plus something like ranitidine. There aren't as good doses of cimetidine in children, and there's a few more drug interactions with cimetidine, so most people use ranitidine. And you could consider the combination of this in treatment of more severe anaphylaxis, particularly with low blood pressure. Beta blockade is a real problem because beta blockade increases the release of mediators, and it may lead to refractory hypotension, bradycardia, and treatment resistance. So you would still give epinephrine, load up with fluids, but what has been done first, if they have bradycardia, is to try atropine, and then a second thing is to give glucagon. And it appears that glucagon kind of does an end around on the beta receptor at the cell surface. It uses some other mechanism at getting into the cell and increasing cyclic AMP. So that is commonly recommended if patients are on like Indoral for their blood pressure or their migraine. Glucagon can cause nausea and vomiting, so you have to be wary of airway issues, get the patient on their side. Glucagon doses that are used are here, and then atropine doses. Now, secondary anaphylaxis therapy, other measures to consider after giving epi, oxygen, and volume would be if there's any kind of pulmonary issue going on, albuterol or levoalbuterol could be given by nebulization. We talked about H1 and H2 blockers. Steroids could be given in asthma-type doses, and certainly if they have asthma, giving steroids would be reasonable, along with nebulized beta agonists. So conclusions, and again, kind of test question core concepts. Rapid administration of epi, IM greater than sub-Q, is a key feature of successful management of anaphylaxis. Maintain airway, oxygen, IV fluid resuscitation are the next important steps. And things like antihistamines, steroids, bronchodilators kind of come after those initial considerations. And be prepared to treat, a very acute evolving condition. Some false assumptions about anaphylaxis. It's always preceded by mild symptoms. It can, as we said, you can get the shock syndrome evolve just within really seconds to minutes. There's no need to rush because there's always time to get to a medical facility. Again, the evolution of this can be just dramatic. The epi doesn't always work, particularly if the thing's kind of on a roll. And mild reactions can evolve into very severe reactions. And antihistamines by themselves are not really very effective in any of the real threatening mechanisms of this disorder. And I still see people just within the last couple weeks who said, I went to the emergency room after I had this drug reaction and I was wheezing and sneezing and itched all over, and they gave me a steroid shot and Benadryl. So I think we still have a ways to go to be thinking about the steps in effective treatment. Now, what do we do? Let's say we're working in our office or emergency room. We've treated them. They're feeling pretty good. The itching's gone. Vitals are pretty good. Then you have to decide whether to send them home or whether they should stay in the hospital for observation. And I think you just have to kind of go with your gut. And based on some of those things we talked about, if it's severe, I think you can very easily justify keeping them in the hospital for observation for 24 hours. If they are going home, think about giving them injectable epinephrine, whether they should be on steroids, should they take antihistamines, discuss the correct use of the devices. If they had a reaction to peanut, there's a lot of complicating factors in trying to educate them and the family about how you deal with that in the future. And then what kind of follow-up do you need? And if the causes are unclear, if it's recurring, you need some kind of consultation help in managing the patient. There's some other measures one might use, like pre-treatment. If, let's say, somebody had a radiocontrast reaction and they have to have another one, how could you prevent a recurrence of that? And people have used these pre-treatment regimens. They get Benadryl an hour before the procedure, steroids, prednisone 50 milligrams, 13/7 and 1 hour before. Ephedrine has been used an hour before. Maybe H2 blockers, low osmolar contrast agents. And if you do these, very often it'll block a recurrence. This is really a family disease in a lot of these allergic, particularly food allergic patients. And it's a chronic disease to the family. The psychosocial effects of this in that kind of situation are much more than I think we realize. And when it's been studied, it's pretty dramatic. So you have to recognize that if there are life-threatening conditions like peanut allergy in a child, it affects the whole family. There's good information at a website, the Food Allergy Network. They have great information and direction on food sensitivities and epinephrine. The patient and family should have an anaphylaxis action plan. Some other things that could be done you can desensitize to some drugs. Usually this is, people who have to have kind of chronic antibiotic therapy for something, we desensitize the patient. We talked about pre-treating for radiocontrast. If the patient has venom, anaphylaxis, yellow jacket stings, immunotherapy for that is extremely effective, probably greater than 90% in preventing recurrence of anaphylaxis. And then educate our office personnel, because they're going to see these patients sometimes coming in, and there should be a plan on how to deal with this so that the outcome is good. So there's some references here. The last reference, number 7, is a symposium on definition and management that just came out about 3 weeks ago, and that's an update on the number 4 reference, which goes over a lot of these issues with great references, and it's easy to read, and I think those would be places to go for you if you want to know more about this or kind of reinforce information. That's a good question. What about Susfrin? Susfrin was a product that was a immediate epinephrine release and then a more prolonged epinephrine release. And I actually thought it was kind of a useful drug. You'd give the patient epinephrine and then Susfrin before they left the office, but it's not available, and I don't think it'll come back. One thing that it's kind of interesting, epinephrine probably stays around longer than we used to think. There's probably some biologic effect for a couple hours, but I agree that it was a useful product, but we probably won't see it again. Yes?
The medications of pre-treatment, are all those IV medications?
No, pre-treatment regimen, they can all be given orally. Yeah, prednisone 50 milligrams, 13, 7, and 1 hours. Benadryl 50 milligrams, ephedrine, and then there's some controversy about whether H2 blockers help or not. There was a study at Northwestern that said that it didn't help, but some people do use that. Yes, ma'am.
What is the relationship between radioactive contrast, iodine, and shellfish?
What is the relationship between radiocontrast, shellfish, and iodine? None. That's the thing I said was the medical urban legend. It's sort of interesting that there was a paper in 1947, I think, about radiocontrast reactions, and 2 of the 7 people had shellfish allergy, and it was said ever afterwards that shellfish and iodine had something to do with radiocontrast, but they don't. And I even know a fairly young radiologist who thinks that they're related, but it doesn't appear to be. Good. Let's say if they have anaphylaxis, how long would they stay on kind of a protective type medication? I think it'd depend a little bit on what the trigger was. You know, if they had, let's say I need to get to acute asthma. If they had let's say a venom sting, they probably don't need that, you know, maybe you might give it maybe for a day to protect against this delayed kind of anaphylaxis, but that occurs usually very quickly, or, you know, within hours, and so you don't really need days of that kind of protection. I think for the most part, you don't need to continue those therapies. Now, let's say somebody had idiopathic anaphylaxis, or they were having acute hiving and angioedema that's a little bit different condition, then they may need, you know, steroids and antihistamines for a longer term. So it kind of depend on the stimulus for that acute event. And it's not always easy to tell between somebody who comes to your ER, your office, with acute hives and angioedema. Do you call that urticaria? I mean, do you call it urticaria angioedema, or do you call it anaphylaxis? I think it's a clinical situation. Usually those people have had hiving before, and this is more an exacerbation of their chronic hiving.
This one? Or this one?
On your anaphylaxis cart, you have 500 milligrams of, 500 cc's of Ringer's lactate bags, 8 bags, and you're telling us to use saline.
Excuse me, would you repeat that?
On your anaphylaxis cart, you have Ringer's lactate rather than saline.
I think I would use saline.
Okay.
Now on to acute asthma, And we have another disease that's can be life-threatening and evolves very quickly. And again, the definitions of this are not easy. How do you define asthma? But we think of it as an inflamed airway, and in that airway there's bronchoconstriction, mucosal edema, airway plugging, and then in more chronic severe asthma, what's called remodeling, and these would be architectural changes in the airway wall. So these airways are hyper-responsive, twitchy, and they're full of debris, cellular debris, and the wall of the airway is edematous. So all these factors lead to increases in work of breathing and impaired gas exchange. And the work of breathing can, with obstructed airways can get very severe and impair gas exchange. If you look at infants and young children, they're at particular disadvantage. They seem to have an increased peripheral airway resistance. Their airways are a little floppier, so it's harder to keep them open. These pores of cone that are these collateral channels of ventilation aren't as well developed, so they get atelectasis more easily. And their smooth muscle patterns are evolving, and they don't bronchodilate quite as well. Their elastic recoil pressures are such that they can't pull airways open by changes in the chest wall and diaphragm. And then their diaphragms are a little lower, so they can't pull airways open as easily. So infants and young children can have asthma or obstructive lung disease evolve more quickly. The differential, particularly in children, is not always easy to sort out. What do you call what a 3-year-old has when they have wheezing and tightness in the chest and a fever? Is that viral bronchiolitis? Is it croup? But those are the things you're trying to think about when you see the wheezing child. And then in more chronic wheezing, you'd have to think about things like foreign bodies, CF, anatomic abnormalities. In the older child and adult, vocal cord dysfunction, we're going to talk about that a little bit with the chronic asthma talk. But these are usually teens or young adults who have kind of a conversion reaction where so kind of subconsciously they have paradoxical movement of their vocal cords and get kind of a stridorous breathing. And then older adults with congestive heart failure. So you just have to think about differential diagnosis when we see these people. There are a couple different patterns of how asthma attacks evolve. Probably clearly the more common is the slow progression. And these are people who have asthma. They got a cold about 5 days ago and had a scratchy throat and then a cough. And over the last couple days, they've been getting tighter in the chest. And this evening, they're using their inhaler over and over and not getting any better. Usually, these are infection triggered. They don't respond very quickly to therapy because there's a lot of kind of chronic inflammation that's evolved. But there are probably 80 to 90% of the people that we see. And then there's the sudden progression people. And these people have very sudden onset of bronchoconstriction. And this has been called acute asphyxic asthma. And they go from being almost normal to being very obstructed in just very short periods of time. Often these are allergen triggered, either something like aspirin that they took or mold exposure out on the farm. And these are maybe 10 to 20% of the patients, but they get sick very quickly. And that's probably more of a smooth muscle bronchoconstriction effect. Those people may even need to carry epinephrine, or they may be the patient you might give epinephrine for if they come in just tighter than toenails. Now, some risk factor for severe asthma, for the reasons we said, infants and toddlers at higher risk. If people have had previous severe episodes, been in an ICU before, have been intubated before, that predicts a higher risk. And some of these people, when they've been studied, may even perceive obstruction differently than the average person does. Their ventilatory drives may be a little different. So they may not sense dyspnea until it's much more evolved than some other people. If they've been in the hospital recently, frequent ER visits, they're on a lot of medicine, they come in and they tell you that they're really sick and they've been on prednisone 60 milligrams a day for a week and using their inhaler every hour, that'll get our attention, I think. If they've had pneumothorax or pneumomediastinum, and things, psychosocial issues are very important. Poverty backgrounds are associated with poorer outcomes. They don't adhere as well, perhaps, to their medical programs. So there are a lot of factors go into who's at risk for more severe asthma. Now, we think about the history, the time of onset, and the cause. Again, like if they had a cold 4 or 5 days ago, how severe the symptoms have been, how it's evolving, what medicines are they taking, and how do they dose that? What are some other medical problems? Do they have cardiac disease? You have to factor all those into evaluation. In the physical exam, in assessing severity, things like alertness, distress, air hunger, diaphoresis, clutching the chest. In the exam, look for air leak, and that would be kind of the saran wrap feeling in the supraclavicular space or around the neck for pneumothorax, pneumomediastinum. Rule out upper airway obstruction, angioedema, or epiglottitis. And these are some features of the more severe asthma. In children, they're too breathless to talk or feed, respiratory rates greater than 2 standard deviations for age. The classic position of the acute asthmatic is sitting forward so to maximize kind of mechanical advantage and using sternocleidomastoid muscles for breathing. And this has correlated pretty well with obstruction, and FEV1s around 25% are predicted. So you see that in adults and older kids. Pulsus paradoxus is the variation in systolic blood pressure through the respiratory cycle. And with these large intrathoracic pressures, you have changes in venous return. And so as you cycle through the respiratory cycle, systolic pressure can vary by quite a bit. And if it's greater than 15 millimeters of mercury as they cycle, that's said to be a significant pulsus paradoxus. Although it's hard to measure sometimes in wheezing, coughing people, but it is a finding that you sometimes see. Tachypnea, tachycardia, those rates depend a lot on whether you're dealing with young children or older kids and adults. And in fact, fairly severe asthma may not be associated necessarily with very high heart rates or tachypnea. Those aren't very predictive. Now, life-threatening features would be the silent chest on auscultation. You actually want to hear wheezing because there's enough turbulence of airflow to be moving air through the airways. Feeble respiratory efforts, cyanotic, changes in sensorium, fatigue are all features of very severe asthma. Some physiology, O2 saturations in the 80s, and these vary a lot too, but I think after therapy, if they're still in the 80s, that's something to pay attention to. Peak expiratory flow rates less than 50% of the best they can do. Hypercarbia, although there was a University of Colorado study in adults, and they did blood gases when people came in to their ER and found a significant number of them had PCO2s in the 40s up into the 50s, and very few of them required ventilation, mechanical ventilation, because they seemed to respond to the therapy. So initial PCO2s or hypercarbia may not necessarily require they be on a ventilator. They may still respond to just usual therapy. Most asthmatics are pretty easy to correct in terms of oxygenation. A few of them, particularly children who are very atelectatic, may be harder to get their oxygens up, but usually it's not too difficult. Now, pulmonary function tests and objective patient assessment. Oximetry is useful in both kids and adults. It reflects both peripheral and central airway obstruction. Peak flow is a test where they use their chest wall muscles to expel air out of real central airways, but oximetry kind of gets at the whole system. There were studies in the 80s that suggested that kids who were treated over 2 hours and still had O2 sats under 91 ended up being hospitalized and did better in the hospital. And that's variable, and adult studies don't follow through with that. But I think looking at saturations is still very important in trying to assess our patients. In physical exam, you can do either FEV1s or peak flow. It's usually easier to do a peak flow, and there's a pretty good correlation in asthmatics between peak flow and FEV1. We'll often give initial nebulizer treatment and then get a peak flow, and then try to have peak flow measurements on kind of in your record before they leave the emergency room or your office, because I think that's good documentation of where they were when they left the clinic.
Sir, how do you use the O2 saturation in your office if you have an acute case?
Just pulse oximeter.
Yes.
Yeah.
How do you,
How do we use pulse oximetry in office asthma? We usually get an O2 sat when they first come in, and then if they require, let's say, 3 or 4 nebs, we'll do it periodically during the time they're in the office, and then do it before they're discharged.
what numbers are reassuring to you?
What numbers are reassuring in terms of O2 sats? I think if you get them into the 90s and you factor that in with other factors, I think that's reassuring that they're doing better. In a study in the 80s showed that if you follow peak flow, it really not till they get 25% of predicted is there a risk that their PCO2s are starting to go up. And so peak flow has been a real useful tool in cutting down on having to do blood gases. If their peak flow is 50 or 60%, virtually none of them are going to be hypercarbic. So most subjects aren't going to really need arterial blood gas determinations. You might do that, though, if there is cyanosis, confusion, fatigue. Again, FEV1 or peak flows below 25% of predicted, or you're treating with repetitive aerosols and they've had steroids and they're still getting worse. They're probably going into the hospital, and you may need blood gases for kind of a baseline. But most subjects don't need that in most office or ED kind of asthma. What about doing chest x-rays? It's usually not helpful in most of the patients that we see. There was a study back in the early 80s that's referenced, and they looked at, I think, about 300 asthmatics that came into an emergency room in Boston, and they did chest x-rays in all of them, and a lot of them had kind of minor abnormalities, hyperinflation or a little kind of patchy atelectasis. And they found that significant x-rays were apparent only in kids who had very abnormal chest auscultation findings, no breath sounds on this side, breath sounds on the other side, tachycardia over 160, tachypnea, temp 38.5 or higher. So the take home, I think, is in kind of garden variety, adult and pediatric asthma, chest x-rays don't help very much if everything else seems to be falling into place. We might do a chest x-ray if they're admitted to ICU or even the hospital for baseline, or if they have a history of heart disease, or you're trying to look at other comorbid conditions. Now, kind of general goals of treatment: relieve hypoxemia, quickly improve airways obstruction, try to prevent relapse. So in ED, type asthma, if send them out, you know, you're pretty confident they're not going to have to come back. And then we need to monitor with objective measures and how they respond to treatment. And I think objective measurements with SATs and peak flows are real important and kind of a core of this National Asthma Education Program. So the established first lines of therapy would include oxygen, beta agonists, and corticosteroids. And again, test questions in acute asthma would reflect that those are the first things you think about. In terms of oxygen therapy, the acute asthmatic has some degree of hypoxemia, although as I said, it's usually not very severe and it's VQ mismatch. So that's pretty easy to correct with oxygen. You can use either nasal prongs or 35% oxygen by mask. Humidification seems to be helpful. The asthmatic who's working pretty hard cools the airway, and that's actually a bronchoconstrictive stimulus. So humidification may help by that mechanism. Kind of shoot for 92 to 95% oxygen by saturation, and then deliver nebulized meds with oxygen at 6 to 8 liters. That seems to help get the particle size delivered more efficiently into the airway. Now, treatment with bronchodilators by nebulization. This is one of the delivery options, and generally the doses are 0.15 milligram per kilo up to 5 milligrams. 2.5 milligrams would be your standard albuterol dosing. So by convention, this is often a neb every 20 minutes times 3, and then maybe hourly, and then observing response. Another thing that's been done in more severe asthma, particularly in, well, both in kids and adults, is continuous nebulization. And they have a setup where 10 to 20 milligram of albuterol, let's say, is put into this reservoir, and then they're just breathing in that continuously. And it's been done safely and is often a way that albuterol would be administered in pretty severe asthma. Although when it's been looked at, it doesn't necessarily have a better outcome than just giving repetitive nebs in a more conventional way. Now, another way of delivering would be a metered dose inhaler, particularly with a spacer. And they've kind of tried to look at drug equivalence delivery, and it looks like 4 to 6 puffs of albuterol with an MDI and spacer delivers about the same amount of drug as a neb treatment. Nebulizer treatments, although they seem efficient, are actually very inefficient. Very little drug gets down into the lung, and you have to give a lot of drug to really get enough down into the airway for an effect. Yes, ma'am?
How much albuterol can you use immediately in acute phase for children? How many puff? And if you know if there is any change with weight?
What would be the doses with?
Yeah, with different weight,
dose,
only for children, yes.
metered dose inhaler with a spacer?
For children?
Yeah.
What
Yeah.
will be the dose?
Mm-hmm. Yeah, a lot of people have made the point that, you know, there's a pretty good safety margin here, and people have used 4 to 6 puffs, you know, even every 10 minutes for hours with metered inhalers and spacers. And you think about the doses with the continuous nebulization, 20 milligrams has been given per hour in children. That's an awful lot of puffs of albuterol. So a lot of the research on how much albuterol you can give is still trying to come up with what are safe doses, and it appears that these are pretty safe drugs in these patients.
One of the reasons we use a nebulizer is because of the saline in there. It gives some extra humidity that you don't get with the MDI.
The question would be, or the comment would be, using saline with the nebulized delivery seems to kind of help with the airway and humidification. When they've looked at, just sort of respond to that, when they looked at the response of using metered inhaler with spacer versus nebulization, in no study can you really show superiority in terms of outcome with nebulizer treatments. And in fact, in very young children, it appears that using a MDI with spacer is actually a little more effective. So I think despite the fact that we all still, and I do too, still use nebulizers in young children, older adults, it's very hard in any kind of literature study to show that that's better than using an MDI with a spacer. In fact, there are a lot of proponents of MDI with spacer as being superior. So just, I think that's a kind of a point to keep in mind and keep following the literature on. I think in children at home with the parents, the nebulizer is still perceived as being a great way to go just for convenience. But again, it's hard to show any benefit over MDI with spacer. Yeah.
Can you comment on the safety and effectiveness of albuterol compared to salbutamol?
What, like Zopanex, is that the one, what you're asking about? Now,
Yes, Ventolin is the one we use, but this is in Canada.
yeah,
We
the
use.
Canadian term for albuterol is salbutamol.
Oh, okay.
Yeah.
All right.
So they're about the same.
Okay.
Now, what about, you know, if giving nebulized beta agonists is good, what about giving it intravenously in very, very sick people? And this has been looked at quite a bit. There's a meta-analysis of about 15 articles that's referenced, and they in their meta-analysis, they looked at people who got IV albuterol, IV terbutaline, and they're unable to show that there is any benefit in using the IV beta agonist. So in the US, it's just generally not done to give these drugs intravenously. Some people still try this if there's impending respiratory failure, but for the most part, that's not standard therapy for folks like us in the emergency room or the office or even hospital. Now, steroids, systematic reviews have shown improvement in symptoms, decreased obstruction, better oxygenation, shorter hospital stays, decreased relapse. Fewer people have to be admitted to the hospital, but just remember again that they have to be given early because it takes a period of hours for them to be effective. And we would, in the emergency room or in the office, give steroid pretty quickly, pretty low threshold, if they're not responding promptly to a neb or metered inhaler administration. I think it'd be reasonable to think about giving steroids if their peak flows are below 70% after your initial treatment. But to me, if somebody's sick enough to come to the office or the ER, they probably are a candidate for steroids, at least short course. Oral administration is as effective as parenteral. Steroids are very highly absorbed, so you can give them orally and it's just as effective as IV for comparable doses. These are doses in children, 1 to 2 milligram per kilo, Cyamedrol. These would primarily be our hospital doses. In adults, in the emergency room, give prednisone 40 to 60 milligrams in people not responding, and then a way to do this would be discharge 40 to 60 daily for 7 days and start them on an inhaled steroid. The doses on steroids are pretty much pulled from the sky, but in pretty good close attention to a lot of different studies by people have suggested that particularly in older kids and adults, anything above 60 milligrams doesn't really add too much. So those are doses that are shot for. One thing that's sometimes done, if the patient is not adherent to therapy, they've given IM depomedrol, 80 to 160 milligrams. In hospitalized adults, think about prednisone 60 milligrams every 8 hours, and then down to 60 milligrams a day after 2 or 3 days. And then we can stop oral steroids within a couple weeks of therapy abruptly without having to taper them. What about inhalation of steroids in ER asthma? And people have looked at this in both children and adults. What about giving, let's say, Flovent by spacer as therapy rather than oral steroids? It just appears that, particularly in more severe children, in the study that's referenced, that it just isn't very effective. In adult asthma, very high doses of inhaled steroids seem to have some effect, but it's generally not thought to be recommended therapy at this time. Anticholinergics, this would be like Atrovent or ipratropium. This has been looked at, and there's a kind of a Cochrane consensus that these have seemed to be effective in particularly the more severe asthmatics. So they've been using Atrovent or ipratropium has become more standard of care in the more severe acute asthmatic. You might use an Atrovent metered inhaler, 4 puffs with a spacer every 10 to 20 minutes, or a nebulized Atrovent every 20 minutes times 3, and then every 2 to 4 hours. And that seems to be of benefit in more significant asthma. Magnesium sulfate's another thing that some ER docs have looked at, and the data are a little conflicting, but there seems to be some benefit, again, in the most severe asthmatics. It doesn't work as well in milder, but it would be a consideration. I just point out that it's not in the guidelines to do, but there is a pretty good literature now that some respond to IV magnesium. Theophylline, kind of an older drug, and it's no longer considered first line in the ER or the hospital, although some people still try this in impending respiratory failure. But in the kind of, again, the asthma we treat, more side effects than benefits. A couple other things that are looked at, Zopanex is a trade name for levalbuterol. It may be a more effective bronchodilator, milligram per milligram. There's a study that showed reduced hospitalization rates in asthmatic children using levalbuterol versus albuterol, and other studies didn't show that advantage. So this is still kind of evolving as to whether using this levalbuterol Zopanex product is superior to albuterol. Leukotriene modifiers, this would be like Singulair and some other products. You can show that in acute asthma, refractory to initial beta-2 agonists, that there was benefit in giving this IV at a higher dose than the 10 milligram montelukast Singulair product we use. And then Accolade has also been looked at, and it appears to have some effect. It just always gets down to whether you've given maximum doses of other things and whether this truly adds on to the more conventional therapy, but these are still being investigated. Then there's non-invasive positive pressure ventilation. That's being looked at in acute respiratory failure and in particular severe asthma, and studies are kind of ongoing as to whether that is going to be something to use to keep people off the ventilator. Heliox is a mixture of helium and oxygen. Work of breathing is related to turbulence of airflow, and because helium is a lighter gas, there may be less work of breathing. The studies have showed some positive, some benefit, and some negative, and I just have a couple references. There's a systematic review that was in CHEST by Rodrigo that didn't really show that this was of significant benefit, but it's another thing that is being studied and you may see in literature. So summary of the therapy approach, if asthma is mild, and this would be O2 sats greater than 95, good peak flows, they've had a couple neb treatments in the office, these are people who are going to go home. you can treat them with, consider an oral steroid taper for maybe 7 days. They should have a discharge plan. Start them on inhaled steroids probably, or make sure they're taking them, and make sure they see their doctor in a specific follow-up. And then moderate illness we might define as people who have been treated for maybe 1 to 2 hours. They've had 3 or 4 neb treatments. You probably have started oral steroids. You may use Atrovent in addition to the beta agonist, and we're doing peak flows and O2 sats to monitor them. Kind of at about 2 hours, it's decision time as to whether they need to be in the hospital or whether you can maybe watch them a little longer and whether they're going to turn around. But 2 hours is a pretty good kind of timing to start making your decisions. All these people would probably be getting steroids. And then the more severe patient, it's pretty obvious that they've been working for a couple hours, higher with significant work of breathing, O2 sats under 90, poor peak flows, and these people are going into the hospital. And they'll get oxygen, beta agonists, and ipratropium nebs, IV steroids. Consider chest x-rays. If they're severe, blood gases. It's all kind of a judgment. There's a talk, I think, later in your session about the management of respiratory failure, but if these people have respiratory arrest, they're intubated, they get 100% oxygen, continuous beta agonist and ipratropium nebs, IV steroids in the ICU. When deciding about admission, I think a lot of this is data, like peak flows and O2 saturations, but you also have to factor in, are they a high-risk patient? Have they been in ICU before? Are they a tough asthmatic? Non-medical social factors are important. In children, you know, are the parents very focused on providing great care, knowledgeable, good judgment, versus the family where there's 6 smokers and 10 cats? So you have to factor all these things into the decision about disposition. And people who go home need to have an action plan. They have to understand how to do their medicines. They have to have ready access to their program, and follow up with you is just critical. It'd be reasonable to think about 3 to 7 days of oral prednisone, and make sure they know how to use their beta agonist inhaler, and they know what to do if they're getting worse again after discharge. So these would be some references that you could look at, and probably the major one would be this National Heart, Lung, and Blood Institute asthma guidelines. But then the last reference, 16, Rodrigo, is a very good review of adult asthma. And then there's also one by Kelly and Murphy that's very good in children. So are there any questions I could? Yes, ma'am.
How can you tell when the albuterol MDI is empty? And how do you tell the patient?
Very good question. How do you know if the albuterol MDI is empty? It's very difficult. You may have been taught to put it in water and see if it floats or goes halfway down, and those things don't really predict whether the thing's empty. The FDA has told all the manufacturers to start working on designs with counters on them. And that will be coming, and there's some products that have that. But I agree that that's a very difficult question, because if you shake it, you can still hear propellant. The drug may be gone, and there may still be propellant in the MDI. So you just don't know. The question in Nebraska is there state law about asthma action plans? What is mandated in Nebraska now is that, and this is through the Nebraska Department of Education, is that schools must have epinephrine and nebulizers available. And that's been pretty well instituted. And there have been studies just since this was done 2 years ago that have shown that there probably have been lives saved by having epinephrine in schools. I know I have a patient who's a 4th grade teacher, and he ate kiwi in a salad and had very severe anaphylaxis, and the school nurse gave him like 3 injections of epinephrine, and the squad took him to the emergency room. So having that in there, you know, was life-saving virtually for this guy. But the action plan isn't really mandated, and that's maybe a school form that you have to fill out. It is encouraged, but I don't think there's a law about having to have that.